Today our topic is overview of Philippine obstetrics. We're gonna see about the obstetric what it is. Like this is the art and science, deals with the delivery, its antecedents, sequelae of pregnancy, labor and puerperium, derived from the Latin word obstetrix or midwife. These are found in the 15th century, the term used worldwide. Historical background. The Philippines unknown period started as practiced by the traditional or the untrained midwives. Before 1908, the practice of obstetrics in the Juan de Dios Hospital. After 1908, St. Paul Hospital, Civil Hospital, Mary Johnston Hospital are used. In 1908 to 1909, 92 obstetrical cases, according to Dr. Calderon, was found. Rest of births attended by the traditional birth attendants or held comadronas and perhaps very few physicians. Aims of obstetrics. Every pregnancy ends up with a healthy mother and a healthy baby. Women health, keeping a woman healthy from the womb to tomb. Their medical uses, socio-economic issues and the political factors to ensure the safe motherhood, lower maternal and the perinatal mortality and the morbidity, improve the quality of life of motherhood and the fetus physically and intellectually and emotionally. Population of the Philippines in 2008 like 1 crore 6 lakhs 65 what else something. You can see the population here in Philippines. In birth, complete expulsion or the extraction of the fetus from the mother irrespective of whether the umbilical cord has cut or the placenta is still attached. Lesser than 500 grams equal to abortus. Absence of weight, length of 25 cm or which is equated to less than 500 grams. 20 weeks equal to 500 grams fetal weight. Birth rate, number of live birth per thousand population or crore birth rate. Fertility rate, number of live birth per thousand female population aged 15 through the 44 years. Live birth, the complete expulsion or the extraction from its mother of a product of the misconception or irrespective of the duration of the pregnancy which after the separation breathes or show any other evidence of life such as the beating of the heart, pulsation of the umbilical cord or definite movement of the voluntary muscles whether or not the umbilical cord has been cut or the placenta is attached. Each product can be live on. Heartbeats, these are distinguished from the transient cardiac contractions. Respirations like these are distinguished from fleeting respiratory efforts and gasps. Stillborn, the death of fetus prior to the expulsion or extraction from its mother of a product of the conception, irrespective of the duration of a pregnancy. Birth weight, the first weight of the fetus obtained after the birth, expressed in the nearest gram, preferably be measured within the first hour of life before the significant postnatal weight loss has occurred. Low birth weight less than 2,500 grams, very low birth weight less than 1,500 grams, extremely low birth weight less than 1000 grams. Gestational age from the first day of LMP. These are expressed in the completed days or completed weeks. 280 to 286 completed days after the onset of the LMP. 40 weeks EOG. If LMP not available, the gestational age based on the best clinical estimate. Tabulations in the weeks and days should be given out. Abortus, an embryo or the fetus expelled during the first half of the pregnancy, like 20 weeks or less, weighing less than 500 grams. Preterm, a fetus less than 37 completed weeks, less than 259 days of the gestation. Term, a fetus from the 37 completed weeks to 42 completed weeks, 260 to 294 days of a gestation. Postterm, a fetus more than 42 weeks or more, 295 days or more of gestation. Perinatal period commences at the 20 completed weeks, 140 days of the gestation and ends at 28 days after the birth. When the perinatal rates are based on the gestational age rather than the birth weight, it is recommended that a perinatal period can be defined to complete or commence at the 20 weeks. Neonatal period, it commences at birth up to 28 completed days after the birth. Early neonatal date, first 7 days of life. Day 0 death, recorded in units of the completed minutes or hours of life. For the second day up to the 27-day age of death are recorded in days. Fetal death data. Fetal death into 1000. Total births, live births and stillbirths. Fetal death rate, weight specific. The fetal death weighing the 1000 gram and over into 1000 total births weighing the 1000 gram and over. Perinatal mortality rate. The fetal death and early neonatal death into 1000 total births. Perinatal mortality rate, weight specific, that is weight of perinatal children, like fetal death and early neonatal death must be greater than 1000 gram into 1000 total birth weighing must be the 1000 gram. Infant death. This includes the death of the live-born infant through the 12 months of age. Infant mortality rate. The number of infant death per 1000 live birth. Maternal death. Death of the women while pregnant or within the 42 days of the termination of pregnancy, irrespective of a duration of pregnancy, from any cause related to cause and aggravated by the pregnancy and management, not from the accidental or the incidental cause. Maternal death group. Direct obstetric death resulting from the obstetric complication, pregnancy, labor, preparium, from the intervention, omission, incorrect treatment, or from the chain of events resulted from any of the above. Indirect obstetric death resulting from the previous existing disease or disease that developed during the pregnancy and which has not due to the direct obstetric causes but which aggravated the physiologic effects of pregnancy. Non-obstetric death due to the suicide, accident, gunshot wound and the like. So the maternal mortality ratios and rate. The annual number of female death in the 1 lakh live births. In the Philippines, the preferred denominator used in the MMR is 1000 live births. Causes of the maternal death. Mortality by main cause. Complications related to pregnancy occurring in the course of labor, delivery and preparium, 38.4%. Hypertension complicating in the pregnancy, childbirth and preparium, 35.2%. Postpartum hemorrhage is 17.3%. Pregnancy with abortive outcome, 9.1%. Other causes of the maternal death, for example, socio-economic factors like cultural factors. The women die because they are neglected as children. They marry as adolescents. They are poor and illiterate. They are underfed. They are subjected to harmful traditional practices. They are denied equal social, legal, economic status and excluded from the decision making. They are denied access to adequate maternal health, including the limitation of family size. Decrease in the maternal death. Uplift the socio-economic and the political status for girls and women. Dispense the appropriate family planning services. Improve the quantity and the quality of prenatal, natal and the postnatal care for all women. Provide the skilled obstetrical care for the high risk and the emergency cases. Strategies of the government. Advocacy laws on the women's health and the reproductive function. Policies and the programs on the population control and the family planning. Safe motherhood program should be improved. Risk of death in women. Teenage pregnancy. Pregnancy after the 35 years old. More than 4 children. Birth interval is less than 2 years. Decline of maternal mortality. The phase out of a TBA is. So, training of the health attendants and midwives and the doctors should be done. More facilities for the delivery provided for the public health as in the lying-ins. Health culture centers, public hospitals and some private hospitals should be well improved, like in blood banks, wider use of the antibiotics, IV fluids and electrolytes if needed. Education of the midwives, GPS and specialists should be given everyone, like postgraduate courses and CME. Perinatal mortality, sum of fetal death and the neonatal death, that is 0 to 27 days. The fetal mortality date or rate decrease of 66% from the 1976 to 1996. Neonatal mortality rate fell 59.7%. Difference in the statistics due to the lack of reporting and follow-up, especially from TBA or the traditional midwives. Reduction of the perinatal mortality. Prevention of the neonatal tetanus and other infections. Improvement of the obstetrical care. Community involvement in the perinatal and the neonatal care. Improvement of the maternal conditions affecting the perinatal death. Related to the maternal care. Health and the nutrition during the pregnancy. The quality of a care during the pregnancy and delivery should be done. Immediate care of the newborn. Stillbirth rate. Complications of the placenta, cord and the membranes. Short gestations and the low birth weight. intrauterine hypoxia, and the respiratory distress syndrome. Neonatal data. The 10 leading causes like ill-defined conditions in the perinatal period. Fetus affected by the complications of the placenta, cord, and membrane. Disorders relating to the short gestations and specifies the low birth rate. Intrauterine hypoxia and asphyxia. Fetus affected by the other complications of the labor and delivery. Fetus affected by the maternal conditions unrelated to the present pregnancy. Fetus affected by the maternal complications of the pregnancy. ADS, disorders relating to the long gestation and high birth rate. Future of obstetrics. More can be done. Improve the maternal care. Multisectoral. Not only the health issues but also the women's socio-economic and the cultural issues. MDG, not met sustained Millennium Development Goals. Reproductive health, gender and the development for women. Economic trainings, EINC trainings, lactation management, education and training. Thank you.